recording, and here is the timer, and here is your question. Ambulance, police. Right, if you have read and understood, kindly begin your examination.
Yes,
Now.
I will wash my hand,
Yes.
introduce myself, confirm the patient identity, and
Okay.
explain the patient the steps of my examination for lower limb neurology. And patient
Foot drop.
foot drop should be exposed whole lower limb and close, just cover his private area.
Yes.
Ask patient
Shorts.
if
Yes.
he have any pain before I start or any pain during my examination. He can just let me know.
Yes. And patient will
Uh,
be in which position?
Standing position firstly,
Firstly,
then I will
then.
examine in supine position.
Yes.
A standing position, I will look for patient from anterior
Yes.
for any muscle atrophy, for any deformity of the leg, for any scar. There is a scar here for stabbing or stripping of the vein. And dressing, I will comment on this.
Yes.
I will let patient turn to the lateral side to see from the lateral and also from the posterior, and tell patient to go to wall and come back to see the gate.
Yes.
And if he can walk in tiptoe gait
Yes.
and heel gait.
Yes.
After I finished all this, I will ask patient to spine lay down for on the couch for me, please.
Yes.
I will complete my inspection for the foot inter phalanx. If there is any ulcer, if there is any sore in the heel,
Yes.
in the palm, on the posterior of the foot. I will now examine the patient for neurology. Start from the tone, see the tone of the lower limb by shaking the limbs and comparing with others, and ask patient to let his leg is floppy. I'll try to elevate it and fold it to see the tone also. I will examine for colonus reflex bilaterally, and for power start from the hip flexion against resistance, where for right side and for left side in compare, and adduction, patient instruction to get his legs together against my resistance, outside also, and examine for knee flexion, extension, and other comparing with others. And now for a foot, right side um, patient he can't dorsiflex his ankle, and left side is fully dorsiflex, and also patient can't extend his big toe and fingers. The left side is fully plantiflexion. He can do it bilaterally complete power. Uh, and now I will examine the patient for reflexes, for patellar reflex comparing with others, and Achilles reflex comparing with others also. Now I am going to examine the patient's sensation. Start from upper thigh for L1, L2, L3, is anterior of the thigh, and comparing with others. And for leg, also for medial side, L4, for lateral, L5, and dorsum of the foot.
How
For
would you do
S1,
that? Yes.
by cotton wool, and
Yes.
comparing with others. Patient
Yes.
close his eye,
Yes.
and I will show the patient sensation by touch his sternum. and ask him if he feel like this. Let me know.
Okay.
And after the sensation, there is a decreased sensation on the dorsum of the foot and lateral aspect. I will now examine the sensation by neurotip or pinprick sensation and the same dermatomes, comparing
Yes.
right side with left side. With my examination, there is a decreased sensation in the right side on the dorsum also. Now I will examine the patient for joint position, proprioception. This by ask patient to know, recognize his finger is up or down and comparing with others, and turning fork. And examination also for reflexes for Babinski reflex on the right side and left side, and ask patient to put his heel on left shin and move his leg on the shin and elevate for coordination.
Yes.
Yes, after that I will try to examine the patient back, because this pain may be coming from the back. See for the back and any tenderness on his back. Okay, and thank patient, cover, and wash my hand again.
Okay. Can you present your case now?
Okay, examine to the gentleman with right lower limb weakness. Patient walking with a stepping gait.
Yes.
He can't walk with tiptoe, and also he can't walk with heel walk. On examination, there is no any weakness. There is a decreasing on the lateral side. Um, uh, there is a decrease in sensation of the dorsum of the foot and
Yes.
lateral aspect of the leg for the fine touch and pinprick. He can recognize joint proprioception and turning fork sensation. Reflexes is intact, bilateral for patellar reflex and Achilles tendon reflex. Power is full for hip, knee, and decrease of the dorsiflexion of right ankle and foot,
So, what
and
is your provisional diagnosis?
is secondary is peroneal nerve palsy.
Injury?
Yes,
Okay.
injury. It could be secondary for an operation he has stripping for vein,
Yes.
or could be secondary for compression in his course from the fibular head down, or
Yes.
maybe upper from the spine or
Sciatic
neurology
nerve.
or from the CNS. Yes.
Okay. So, how would you conclude or confirm your diagnosis?
I will send for a patient lumbar MRI. I will do for him nerve conduction study and EMG also.
Yes.
Maybe patient need for MRI.
Okay. What is the treatment that you can offer this patient?
This according, if he is acute, I will do for a head, leg support by ankle foot support or
Yes.
splint
Yes.
to prevent injury, and physiotherapy, weight, and if no improvement, maybe patient need for neurolysis or nerve graft.
Okay. Tendon transfer.
Yeah,
Okay. Good.
yeah. The final, yes, the final stage of surgery if fail of neurolysis is nerve tendon transfer.
Good. Time over exactly. Okay. Now it's time for feedback. Yes.
I forget tunnel sign really.
Yes, Tinal sign
Yeah,
you forgot. And when
yeah,
you were starting palpation, you make this your habit whenever you have to examine something. And for palpation, you should go for temperature first. Feel the temperature if it's equal on both sides or raised in anyone. And then feel for the tenderness if there is any
yeah.
tenderness in the course of common perennial nerve. Then you could have looked at, you even missed the popliteal fossa if there was any mass in the popliteal fossa. You should have examined the. You did say you'll examine the knee joint and everything, but popliteal fossa was to be ruled out as well. The antennal sign you already know. Sensation, motor power. Yeah, rest you all did. Yeah.
Yeah,
So
I believe
just 30-second extra that I asked you to present your case, that would have been covered if you would have
if,
discussed the temperature and tenderness, etc.
yeah, yeah.
Antennal. Yes. Good. Yes. Anyone else want to give feedback? Yes, Dr. Suman.
Yeah, he did well, ma'am. The only
Yes.
thing what you mentioned, the
Yes.
palpation of popliteal fossa,
Yes.
tenal sign, and yes, before going for palpation, he should say that do you have any pain or something? You have to ask the patient about if patient has any pain.
Yes.
That's the only thing.
Yeah. Yeah. Otherwise, it's this time he remembered to thank the patient, to wash hands, and to ask for cover up. So this is
Yeah,
good
yeah.
from
Yeah.
compared to last time. So,
Yeah,
but
yeah.
don't, when you're doing examination, don't be in a hurry. Take your time. All your 6 minutes are yours, so you have to consume it.
Yeah.
That's what my advice for next time. Thank you. Timer has been started, and here is your question. Right. If you have read and understood, kindly begin your examination station.
Yeah, thank you. So before beginning the examination, I'll wash my hands. I'll
Yes.
introduce myself, and I'll ask the patient about the identity. I'll check that. Then I'll explain that I'm going to examine the right hand and upper limb of the patient, and because of the problem she's having, and it will involve the looking, feeling, and moving the arm. And I'll try to be as gentle as possible, and she should let me know if there is any pain at the moment or maybe later on during the examination. So I'll have a verbal consent of the patient,
Good.
and the position of the patient will be lying down with the arm by the side on a pillow,
Very good.
and
Yes.
the whole arm and the shoulder area and chest area should be exposed for this. So I'll begin my examination by inspection. In inspection, I'll look for the site of the fistula. So
Yes.
it could be brachiocephalic or radiocephalic in the wrist area, brachiocephalic in the brachial or cubital fossa, and it could be transpositioned brachial or cephalic AV fistula also. So then I'll look for size of the fistula and scar marks, and then in inspection, I'll look for overlying skin changes if
Shape
there are
and
any.
surface and the overlying skin as well of the fistula.
Yeah.
Yes.
So overlying
Now,
skin,
yes.
I'll check for pigmentation. If there is brown pigmentation, it could be due to venous insufficiency, thinning of
Yes.
skin. It could be any ulceration of impending rupture of the fistula.
Yes.
Then I'll check
Upper
for any
extremity. Yes.
aneurysmal dilatation in the inspection. So then I'll inspect the upper extremity
Good.
for collateral circulations if there are formed any due to obstruction. And then I'll perform arm limb
Also
elevation
for
test.
color and edema.
Yes. And then I'll perform an arm limb elevation test in
Good.
which I'll tell the patient that I'm going to lift the arm, and
How
I'll
would you do it?
take the consent of the patient.
Yes.
I'll lift the involved upper limb suddenly, suddenly extended and flexed above, and during that normally for at least 30 seconds.
Yes.
And during that time, normally AV fistula should decrease in size. Yes. But if there is obstruction, it does not decrease. So this is a test to check the outflow venous obstruction. Good. Yeah. So and then I'll move to palpation. In palpation, I'll palpate the temperature of the fistula. If there is any inflammation, temperature could be raised. Tenderness, again, in inflammation, it could be tender. Then I'll check the distal pulses, both radial and ulnar pulses and brachial pulses, if they are palpable. Then I'll check the AV fistula pulse with fingers of my hands, because that's the best way to check them. Normally, there is no pulse or very mild pulse on the venous side of the AV fistula. But in outflow obstruction in the venous side, distally, there could be a pulse palpable. Then I'll check for the thrill of the fistula with the palm of my hand. Normally, there is a thrill present, which is soft, but in obstruction, there could be increased thrill over the distal site of the venous obstruction. Yes. So after palpation of the thrill, then I'll check for any ischemic changes over the limb with pale and bluish discoloration of the hand. And then I'll perform augmentation test, in which I will manually compress the venous side. This should normally increase the radial pulse of that side, and a pulse could be palpable distal to the site of the obstruction in the AV fistula. So this is called augmentation test, which is normal. So in outflow obstruction at the arterial side, there will be no increase in radial pulse with this augmentation test. So after completing this palpation, then
how would you confirm the direction of the flow?
Yeah, so first I'll check the site of maximum flow, which is a juxta anastomotic site, which is the site of the maximum flow. So I'll first palpate that site, and then I'll go along the radial artery or the arterial side distal to that. If I'm not able to palpate that area, that means it's Steele syndrome is impending and or going on, and the blood is not flowing along that. So after palpation, I'll go for auscultation, in which I'll auscultate with a cone of the steth for the arterial and venous bruit. Normally, it's a mechanical, very mild bruit, which is palpable, but with the outflow obstruction, which it is a strong rumbling sound of the bruit, which is heard. Then in auscultation, I'll auscultate the heart for any kind of murmur if present. This completes my
with Doppler all the
yes. I'll evaluate with the Doppler the arterial slide.
All the upper limb.
Yeah, pulses. And then this completes my examination. I'll thank the patient, ask to cover up and wash my hands again. So I examined the 65-year-old female who was on dialysis and presented with discoloration of right hand. On my examination, the augmentation test was negative. There was no augmentation, and the pulses distal to the site of the anastomosis is not palpable, and there is the temperature of the hand is decreased. Along with that, the thrill is increased, and the pulses are palpable. And my main diagnosis for this is dialysis-associated Steele syndrome or ischemic Steele syndrome.
Okay, how would you differentiate between dialysis ischemic Steele syndrome and ischemic monomelic neuropathy?
Yes. Neuropathy. So basically, dialysis-associated Steele syndrome is when the blood going distal to the site of anastomosis actually goes backwards. It's not going on that side. Yes. So in this case, this is basically outflow inflow obstruction to the hand. So there is pain and cyanosis of the hand. The hand will be cold, and in this case, the radial pulse will not be palpable in Doppler. There will be no or mild decrease of the radial pulse, which will be heard. But in ischemic monomelic neuropathy, it is basically it's ischemia of the nerve, and in this there will be numbness and paresthesia of the hand, and there'll be wasting of the muscles could be there, contractures could have developed, and there'll be weakness of the hand. There will be no dorsiflexion, or median nerve and ulnar nerve will be examined, and I'll check for the weakness of the muscles supplying supplied by these.
Okay, how would you investigate your patient?
So I'll get the arterial duplex scan done in order to check for the patency of the radial artery.
Then what treatment options would you offer to your patient?
One is band ligation of the fistula proximal to that in order to increase the flow, but that's a temporary measure. So second is ligation of the main fistula and creating another fistula proximal to that.
Very good. Okay. A few seconds are left. When you are auscultating fistula like this one, AV fistula, what kind of it's audible sound? What kind of sound is audible?
It's a mechanical rumbling, brewing.
Yes, machinery type.
Yeah, machinery,
audible,
mechanical,
yes. Low pitch,
soft audible.
brewing, yes.
Yes,
this
low pitch.
You have to, which systolic or diastolic component?
Both systolic and diastolic normally.
And no murmur is heard. So this small thing you can add when you're presenting your case.
Yes, I forgot actually. Yeah, it's important.
Because it's important. It explains what you have examined.
Yeah, it is important to differentiate
between. Yes, good. Otherwise, it was superb. Nothing. You give me no excuse. What are they writing? Systolic only? No, it's both. Who is writing this?
So normally it is both systolic and diastolic in thrill as well as bruit.
Yes.
But with obstruction, yes, it is systolic
with
only, and it will be high pitched.
Yes. But with the normal one, you hear both.
Yes.
Yes, that was my point. Like if you get any pathology over there, so only systolic will be more hard, and normally there will be both systolic and diastolic components. Yeah.
Good. Give your feedback, Dr. Abhishek, please.
No, it was really good. Dr. Abhishek asked every point actually, and he was just describing also the findings. So yeah, it was really good. And in examination, I guess what Dr. Sandhu actually shared with us, whenever you tell about the certain things, like about the inspection one, about the palpation one, then the simulator examiner will give you the finding, verbal finding. Okay. As there will be no patient, you have to go to a diagnosis according to that. So in that way, it will be taken. So it's really good.
Yeah. So see, I told you he is good. So got the right station for him.
Yeah, as Dr. Abhishek said, that the examiner will be narrating, telling the positive findings. So that's the main fear.
Yeah.
During the examination, you are mainly focused over your examination, and
you have to remember that.
To say. And suddenly he says something, and you may forget in the end. So that's the main fear in the examination. But I think with the practice over here, slowly.
I also tried to ask questions in between. How would you do what? When you were explaining, that's what I came to know.
But along with that, Dr. Samin, I think you can see the positive findings also. Like, okay, you have examined this. This is what they said in yesterday's webinar also. So they'll be saying, for example, augmentation test. Okay, assume that it is positive. They'll tell 3-4 findings during your narration of the story, and in the end, you have to say all these positive things in the end. So this gets a little difficult, but I think slowly.
All right.
I think for this station, actually, the difference at the end of the notes, right? There will be like peripheral temperature tenderness, peripheral temperature change, and about the neurological symptoms you have done already. So that will be main differentiating point. So I can think we can only focus what the examiner says regarding the differential findings, like if there is a normal temperature or if there is a decreased temperature. That's a major point for this station. So it indicates
Yes.
ischemia or neurological. Yeah. So other than focusing on this, all this augmentation and thing, because whenever there is stenosis, there is some obstruction, you can get both, right? You can get also ischemic monobilic neuropathy or dialysis ischemic still syndrome.
True.
So the main differential is here, like for obstruction, both can happen. So what can happen? We have to find that. So my main point is about these two differential points, not that what is the examiner is saying about the pulse augmentation, about the pulsatility, about the thrill. So what you get on the peripheral neurological examination, and if there is any motor weakness over there or not, so that should be the main differentiating point for this station, I guess.
Okay, good. And if I can reconfirm what Dr. Prabhajit Singh said yesterday, they said they tell you findings when you're narrating the examination. Okay.
Yeah, along with your examination, while you are describing it, they will tell few findings.
Okay.
Few findings.
All right.
Yes,
so,
yes.
And you have to remember that, and during your explanation of the things which you have examined,
of course,
you have to say those
remember that.
in the summary. You have to
okay.
say those.
During summing up. All right. We'll practice it like this, right? Okay.
Yeah.
Right. Yes.
I can add that one thing. He
Yes,
do
please.
it.
Yeah, sure.
He do it perfect, really. I'm surprising. It's very nice. But comment on the needle sign. Is that mean the shunt is working well, and he still use it. There is a needle mark.
Yes, he did the arm raise test and he realized that it was functional. But like if you want to show if there is obstruction, then you can tell. And even we discussed how the murmur or the sound would be.
Yeah.
If there is obstruction, only systolic will be heard. The diastolic component will not be heard. Is that clear?
Yes, clear.
I think he asked something else.
I want to comment on needle mark. If there is a needle mark, that's mean the patient.
That's on inspection.
Still using this stand. Yeah.
Which mark? Which mark?
Needle mark.
Yeah, the needle mark. Needle mark.
Yeah.
If there is any needle mark of recurrent hemodialysis or not, that's
okay.
mentioning.
Then you can get the idea that patient has had previous.
Yeah.
Yes. On inspection.
That's very good. Yes.
The shunt is still using. Yeah.
Yes. It's still being used. Yes. Good. Thank you. So if you're ready, can I start the timer?
Yeah.
Okay, timer has been started and here is your question. Just 2 lines. Right, if you have read and understood, kindly begin your examination station.
Okay. I'll interview, then wash my hands.
Dr. Fatimata, you can't hear you.
Okay. I'll enter the room.
Yes.
Again, I'll wash my hands.
Yes.
Introduce myself to the patient, and then confirm the patient's name and details. And then I'll I'll explain the procedure to the patient that I want to do a hip examination, checking his upper part of his joint, the upper part of his leg around the hip. And then also if there's any pain that he should let me know. And then also I'll take consent from the patient. So then I'll expose the patient from the chest down. I can leave the patient in their shorts.
Yes.
Yes.
And
So
patient
I'll
will be in which position?
stand in position.
Yes.
So I'll put a look, feel, and move procedure. So I'll first start with tell the patient to face me first, and then I'll look for the position of the patient, whether the patient has been slanted like the shoulders, and then the hip as well, the superior, yeah, anterior superior iliac spine to see if it's tilted or not. I'll also check the patient's sides and check for any um, um, abnormalities as well. Check for any flexion deformities on the lateral aspect of the patient. Also check the back of the patient. I'll tell the patient first before going to his back that I want to go to his back. Then I check his lumbar spine, whether it is straight or it is being deviated. And also check for the buttocks, whether there is any wasting for the gluteal muscles or not. Then also I will check for the patient's how do you call it, the gait. I'll ask the patient to take a walk to see if there will be any tilting to the side to check for any positive Trendelenburg back
Patient
test.
has Trendelenburg gait. Positive.
Okay.
Okay,
So,
move on. Yes.
so then I will then move the patient to the field. Now I'll go and fill the superior area spine. Asking the patient, but then by then I'll put the patient on bed. I could do that, and then feel for the pubic symphysis as well. Start palpating, but before then I have to ask for the patient for area of pain first.
Okay.
Hello.
Yes.
So I'll confirm that the patient so I check for the anterior superior spine for any tenderness, for any discrepancies in them. And also I'll check for the pubic symphysis if there's any tenderness. Also, I'll check for the greater trochanter of the hip to see if there's any tenderness as well. If then I then do the measurement of the limbs. I'll check for any discrepancies in the leg length as well. So beginning from the cyphisternum to the medial malleolus, or to the from the ASIS to the medial malleolus. Then
Okay,
after
there is discrepancy of 4 centimeter of femoral origin.
okay, so then I will then go to do the range of motions. I'll check the flexion. I'll check the rotation, abduction, and adduction. So I'll check all those, but then I'll have to tell the patient if the patient is feeling any pain, let the patient let me know. And I also do extension of the limb. I'll also check for any do the flexion of the hip to check for any signs of psoas irritation as well. I'll check for the gluteus maximus and medius if they are incompetent or not. I'll also check for the adductors as well. So then I'll move to do my special examination,
Yes.
whereby I do the Thomas test
Yes.
to check for any flexion deformity of the hip.
It will be positive. Thomas test is positive. What else would you do?
That's what I will do for the special test. Because I've already done the Trendelenburg back.
Okay, what about Gillespie test?
I'm not getting you.
Yes, what about Gillespie test?
Okay. Okay, then we'll do the Gillespie test.
Or it has been done? Has it already been done?
Okay.
I'm asking you.
No, I've not done it.
What was that when you measured the discrepancy of the legs?
Okay.
You don't know. Okay, supratrochanteric origin. How would you? Okay, what else would you do?
I'm not getting you. I'm not getting you. Sorry.
What else? What else would you carry out? What else test, or what would you do next? How would you confirm the movements of the hip joint?
Yes, I said we'll do the extension,
Okay.
flexion, adduction, and then
Okay,
rotation.
can you present your case now?
Okay, I've presented a 66-year-old male that presented with right hip pain. So on examination, the patient had a positive trendyline back gait with a positive Thomas test, and then there was leg length discrepancy of 4 centimeter.
Yes. So what is your differential diagnosis?
So because the patient is 66 and then with the age, I think that maybe a patient has an osteoarthritis of the hip.
Yes. Okay.
Yes. So,
What else
and then,
are you going to consider? Pseudogout or inflammatory or interactive arthritis?
yes, actually,
Okay. How would you
inflammatory.
investigate and manage this patient?
So I'll start by doing a hip X-ray for the patient and the standing position, and then also I can also do an MRI to confirm, and also do inflammatory markers because we are suspecting maybe the patient has inflammatory causes or
Yes.
infective causes. Yes.
Yes.
Okay.
So
And
how would you manage the pain of the patient?
so I would manage this patient according to the WHO pain ladder.
Yes.
So I'll start the patient on analgesia. Most likely, I'll give the NSAIDs instead to see if the patient will with the paracetamol or that's the known or any known opioid or with opioid. So if the patient is not improving on them with the physiotherapy, I can also move to giving intralesional injection, that is intraarticular injection of steroids. I can also do that. So, and then if patient is not also improving on that, then I offer the patient a surgical management whereby I can do arthroplasty for the patient.
How would you, during your examination, you'll rule out if a patient has osteoarthritis or not?
So during the examination of checking for osteoarthritis, there's usually a how do you call it? Crepitus being felt when you are doing the range of movement.
In case of osteoarthritis, extension will not be carried out because of fixed flexion deformity.
Yeah, they will have flexion deformity fixed, and then sometimes they can even have swelling of the knee with varus deformity as well.
Okay, this comes more frequently than every fistula. Is that what you're saying, Dr. Vishek? Okay, can you please give feedback to Dr. Fatimata?
Okay, ma'am. Dr. Fatimata, you did really well. But yeah, like you could have gone according to your chronologically, like look, feel, and the move, and the special test. These 4 things for any type of joint. So in this case, actually, ma'am said that there was Trendelenburg's gait, and also there was like shortening, something like that. So yeah, so you could tell that right hip osteoarthritis associated with isolated superior gluteal nerve injury. Both are there because both sides you have got. And according to the chronology, actually, so at first you'll inspect like any swelling, deformity, overlying skin, muscle wasting, something like that or not. Then you'll go for the palpation. You did all these things like you check the temperature, and whenever you say that you'll check temperature, you'll say just to check temperature around the hip joint. And then tenderness, you can mention some points over there, like there is anterosuperior spine point tenderness, and after contracting the adductor muscle, you can check the tenderness over the adductor, then greater trochanter and over the ischial tuberosity. These 4 points actually mainly important regarding checking the tenderness. Then you can check the femoral pulse, and after that, before starting any movement, you should do the Thomas test to check if there is any fixed flexion deformity over the hip joint or not, which occurs due to osteoarthritis. So whenever you find some fixed flexion deformity, so you are not allowed to do the extension of the hip joint, like the passive extension.
Okay.
Okay, so the patient will not be able to do that. He will feel much pain, and yeah, that will just give you a bad impression. So that's why you just avoid the extension one. Then you will go for the leg length discrepancy, the apparent one, the true one. For true one, you have to do the pelvic squaring, and after that, whenever you find some discrepancy over there, then you will proceed further for the Galeazzi test and measuring the subtrochanteric length. So if you find that there is no discrepancy over there, then don't have to do the test like the Galeazzi test and measuring the subtrochanteric length. So if you get that there is discrepancy, then you have to decide that what is it. It's like femoral or it's like tibial. So you do the Galeazzi test. I am sure that you know how to do it. And after that, you have to measure the subtrochanteric length from the greater trochanter to the tibial tuberosity. So if on both sides that is normal, then you have to come to a diagnosis that it is supratrochanteric leg length discrepancy. Am I clear?
Okay, yes.
And during the passive movement, you definitely must check about the crepitus, because in osteoarthritis, you'll get some crepitus over there. And in any joint crepitus, you'll check that during your passive movement. So we can do these two things together.
Okay.
So that's my feedback.
Yeah. Good. Yeah. If you'll just go back and practice this, it will become perfect, hopefully.
Yeah.
And today, okay.
You are not recording. Yeah.
I am. Yes. Now it's your question.
Next one, I'm going to go for this one.
Right. If you have read and understood, kindly begin your examination station.
Okay, first of all, I'll wash my hands, greet the patient, and introduce myself that I'm one of the surgical candidates and I am going to examine your knee. And I do understand that you are in pain. Do you need any painkiller before your examination? And this examination will involve looking and feeling from the front, sides, and back of your knee joint, of both of your knee joints. And this examination will not be painful. If it is, you can always tell me, so I would be careful. And additionally, I would need him to be exposed up to the underwear, and so that I may be able to see the joint below and above. Above the knee joint. So on inspection, first of all, I'll ask the patient if he can walk. If he is able to walk and stand, I'll ask him to take a few steps away from me, then turn and come back. In this way, I'll examine for any scars, any swelling, symmetry of both of the knee joints, if there is any visible deformity, any erythema, sinuses, or muscle wasting. I'll confirm these findings from the front, sides, and back of his knee joints to see if there are any scars, swelling, symmetry of the joints, deformity, there is any erythema, sinuses, or muscle wasting. Then I'll ask the patient to lie down while the patient is
has
lying
antalgic
down.
gait, okay? Patient has antalgic gait. Now you go on with palpation, okay?
Okay, so patient has gotten antalgic because he must be in severe pain. So I'll ask the patient to lie down and ask for him that I'll now touch his knee joint and examine his knee joint. If he feels pain, then he can tell me. I'll check for the temperature and tenderness over the knee joint, over his bony prominences, over both the over medial and lateral aspect of the knee joint, over tibial tuberosity, and I'll check for tenderness over the quadriceps muscles, and I'll check for any effusions over the knee joint, and if there is any deformity of flexion. I'll ask the patient I'll put my hand under his knee, and I'll ask the patient to extend his knee and push my hand down to check if there is any fixed flexion deformity. After that, I'll assess his movements. While assessing the movements, I'll ask the patient to extend his knee, flex his knee joint, and during these movements, I'll palpate his knee joint to look for if there is any crepitus during these movements. And I'll note if there is any crepitus during these movements. Then I'll move onwards to some special tests to do for if there is any deformity of ligamentous injury. First of all, I'll ask the patient to flex his knee joint to 90 degrees and look for if there is any sagging of the tibia downwards over the femur. This is the posterior sag sign, and then I'll proceed to the posterior draw test, and by placing my thumbs over the front of his knee joint, I'll slightly push his knee joint backwards to see if there is any posterior movement. This is posterior draw test, and then I'll proceed with the left hand test. I'll ask the patient to extend his knee joint, and I'll ask his patient to keep his knee joint at about 20 to 30 degree of flexion by placing my left hand over to the thigh of the patient, and the right hand, with the right hand I'll pull his lower leg upwards to see if there is any anterior draw test positive. So additionally, I look for collateral ligaments injury by
Anterior draw test is positive.
Anterior draw test is positive. Okay, yes. So additionally, I'll perform the valgus and varus movements to check for medial and lateral collateral ligaments injury. And then I'll check for patella if there is any tenderness over patellar movements and if the patient is having any pain over patella. And additionally, I look for his neurovascular status by checking the pulses and sensory levels L2, L3, L4 over the medial aspect of lower leg and L5 over the lateral aspect of lower leg and S1. And I'll have already checked his movements, and additionally, I'll check for his reflexes.
Good.
And
yes.
Okay, I'll thank the patient. Good. And ask him if he needs any help while dressing, and yes. I'll wash my hands and thank the patient.
Good. Now, can you please present your case?
A
1 minute first.
young footballer.
Yes.
A young footballer presented with complaint of sudden pain in right knee on examination. He has a slight redness over his right knee joint, and he has a slight redness over his right knee joint and a slight swelling over the front of his knee joint. However, his movements are pain-free. Active and passive movements are all possible, and he has straight leg raise test is positive, and there is a positive Lachman's test indicating an anterior cruciate ligament injury, while there is no valgus and varus deformity, and there is no pain over patellar movements.
So what is
patient has got?
Yes. What are your differential diagnosis?
My differential diagnosis is that patient may have a fractured lower end of,
patient may be suffering from anterior cruciate ligament injury,
Yes.
or he may have an additional meniscal injury or simply an effusion of the knee joint.
Okay. How would you confirm your diagnosis?
I'll confirm my diagnosis by doing X-ray, digital X-ray, and anterior, posterior, and lateral views and standing position of this patient
Weight
to
bearing
look
X-ray
for any
of the
injury,
knee. Yes. Yes.
weight bearing X-ray of the knee.
Yes.
And additionally, I'll ask for his labs, and I will need his MRI to
Okay.
rule out the soft
MRI
tissue
to rule out,
injuries.
yes, meniscal tear. How should the patient be managed then?
Patient should be managed with bed rest,
So
bed rest, and
conservative management including bed rest, yes,
yes,
and then
yes, he will have a conservative management with bed rest, pain relief, and
yes,
physiotherapy,
yes,
and he will be needing
intraarticular steroids maybe.
uh,
And if conservative management fails, then what can you offer to your patient?
if conservative, then he will be needing surgery for anterior cruciate ligament repair,
Okay, you'll go direct to
which can
surgery.
be done
Maybe you
after
can
surgery.
offer arthroscopy first and arthrocentesis, then
Yes,
you
I
can
will
do,
offer an
yes,
arthroscopy and okay.
yes,
Hmm.
good, excellent, exact on time, very good. Yes, anyone, Dr. Abhishek, maybe you or anyone can give feedback. That's good.
I want to say that weight
Yes,
bearing X-ray is not done in injury case.
it's
It's
not
only
done.
in
Okay,
Yeah,
it's only in osteoarthritis
all right, good. Thanks.
because
I
he has
didn't
history.
even
for
I
our
didn't know that.
discussion.
Yeah.
Yes, it's good to have orthopedician with us.
Yeah.
Yes, thank you.
Yeah, of course. But
Okay.
Because
yeah,
he
actually,
has,
So he
yeah.
was telling right. I made him say wrong.
yeah.
Sorry.
It's okay, ma'am. So I was also a little bit confused. So
Because
it's better to have it
he
corrected.
is
Yeah.
unable to walk. He is
Yeah.
in severe pain. He cannot
Yes.
stand on his leg.
Yes.
The
Good.
best
Thank
Yes,
you.
you're right.
Yes.
is
You're right.
MRI in this case.
Best is MRI. Okay.
But
Is
you
an
can do the
MRI
X-ray.
for meniscus to rule out meniscus tear?
Yeah, all the
Yeah.
ligaments
Yes.
to rule out
All the
ligaments.
ligaments, Chairman.
Yeah.
But the first and foremost is X-ray.
First and foremost is X-ray to rule
It
out
could
any
be a
fracture.
bone injury also.
Any fracture. Yes.
And even posterior cruciate ligament injury, sometimes avulsion injury could be seen in X-ray on the
Yes.
lateral view.
Yeah. You are
The
right.
second is MRI.
Yes.
I think they like MRI. Way to say MRI.
But still, the
So
confirmatory test is MRI for all the soft tissue
for the
injuries.
ligament and yes, soft tissue injuries. So in the management part, I would like to add that, for example, in this scenario of sports injury,
Yes.
and there is one scenario in the ankle examination also where we have a ligamentous injury of calcaneofibular ligament. So in sports injuries, what we make a mnemonic for management is RICE therapy,
Yeah.
RICE. So it's easy to say. I mean, rests, ice packs, compression bandage, and elevation of the limb. So we can do that over
Yeah,
here
you're
also.
right.
Not
You're
compression
right.
in the knee. Compression should not be done in the knee case, but in ankle we can do that with a crepe bandage. Elevation, rest, and ice therapy for the along with the pain medication, of course.
Good. Thank you.
Also, we can add it for the treatment. Patient can use a stick or crochet to help him
Yes,
during.
and
Dr.
bracing
Prabhat,
can also be done.
excuse me, the full mnemonic is price. So first is the pain
Price.
control, then the rest, ice,
Yeah.
compression,
Yes,
and
yes.
elevation. Yes, you're right.
Yeah, price is good.
I don't
So,
hear he do a batellar tap test or no for effusion, joint effusion.
He looked for a fusion.
He do batellar tap test.
Patellar tap.
I don't remember also, one.
Yes,
So yeah,
Prakash, did you do particular tap test?
Yes, I did check for a few years, but I haven't mentioned actually the patellar tap
Yeah.
test. Like
Okay.
same test. You're right.
Okay. I have to say something if that is
Yes.
okay, ma'am. Yeah, actually, Dr. Kashif, you really did well, but I'm just mentioning some, some points regarding the examination. So whenever you just do this knee joint examination, I can remember like above the knee joint, at the knee joint, below the knee joint, what I have to do. Like above the knee joint, you can check the quadriceps circumference and the SLR test to check the quadriceps apparatus is okay or not, if there's any quadriceps tearing or not. Then over the knee joint, then you can start with the temperature, tenderness, popliteal fossa masses and popliteal fossa pulses. And after that, you can do the patellar tap and the pulse test together. And after that, then you just, in this case, like in the stem, it's written that patient is in severe pain, he's unable to walk, kind of like that. So in this station, we are never allowed to do the special test. So you can assume that you can say to the examiner, like, as the patient is in severe pain, I think the patient will not allow something like that, but you definitely mention about every test. And whenever you just briefing about something, you can like, whenever you have told like, I will ask the patient to flex the knee, extend the knee, not like that. I guess you can ask the patient, can you please bring your knee towards your chest? That will mention about the flexion, right?
No.
Can you please
Yes, yesterday,
yeah.
Dr. Abhishek, about this point
Yeah.
that you said, the layman language or the
Yeah.
medical term. In the yesterday's
Yeah.
session, they have clearly said that this time you don't have to say the layman language. It is like you're discussing
Yes.
with your consultant. So
Yes.
over there,
Okay.
you can use
I did
medical.
not have heard of it. Thank you so
This
much.
time
Yeah.
you can do
Okay.
that.
Okay, so that's why it was kind of communication previously with the patient also. So I thought that, and we discussed it previously, that we do not use the medical jargon and everything. But if they have said that yesterday, that's really, thank you for enlightening me.
But only in examination station, not in history taking.
Okay.
And not in
okay.
communication.
It's sometimes really hard.
In examination
really
station,
hard to,
whatever
like,
you know,
explain.
you just tell them every
Okay,
technical
that's
term
really
you can say.
really Dr. Suman. Yeah, that's really
Yeah, what they told yesterday, they were actually, I think, examiners, and they said that we may meet one of you in the exam. So I believe they were examiners. So what they said is, assume this time that this examination station will be like you're discussing with your consultant before going for an operate, or you're discussing with your consultant in OPD over a cup of coffee. So you just discuss or narrate
like
things
asking what points you will say
like
for
that.
the patient. My consultant is asking.
Yeah, think like
I
that.
guess that.
Think like that.
That's really good. Yeah, that's pretty much easier than previous one. So and about the special test, Dr. Kashif, if you remember, according to the ligaments, actually, whenever I first performed this exam, I can remember I also missed some ligaments, like you have missed the mentioning about the MRCS and Lachman test. So if you just remember according to the ligament wise, so it will, like, you'll never be able to forget them. So at first focus on the anterior cruciate, posterior cruciate, then medial collateral, lateral collateral, then about the meniscus. So that will help you. Like during the examination, we have a lot of stress, so we can miss any of the special tests. So if you just remember the ligaments, then it will help you, I guess.
Yeah, you're right. I have made it from posterior to anterior and from medial to lateral.
Yeah.
And yes, I missed the
so you just remember
today.
the ligaments.
I missed the meniscus. Yes, right.
Yeah. So just remember about the ligaments. It will help you to do mentioning about all the ligament, all the special tests. Yeah.
Yeah, you're right. You're right. Thank you.
Thank you so much. Yes. Good. Thanks. Thank you, Dr. Abhishek. And Dr. Suman, of course.
Yes, ma'am. Please start.
Okay, and timer has started, and here is your question. Right. If you have read and understood the question, kindly begin your examination station.
Yes, ma'am. After entering the station, I would greet him, and I would just wash my hands and greet him and introduce myself as Dr. Varki, one of the exam candidates, and confirm his name and age.
Yes.
Then I would explain to him that I will be examining his ankle, which includes looking, feeling, and moving his ankle joint, and take a verbal consent whether he is okay with that. Then
Yes.
I would like to examine the patient in a standing as well as sitting position with his ankle exposed up to the knee.
Yes.
Then initially, I would ask the patient to explain to the patient that if he is having pain at any of the time of the examination, please tell me so that I can stop the examination there. So I will ask the patient to stand up for me, and I will see the patient from front side, and back, and ask the patient if he could walk and check for the gait.
A patient who has
And
antalgic gait.
also, then I also look for any scars, any swelling, deformity, and any wasting of the muscles. Then I will ask the patient to sit for me, and then I will look for any local rise of temperature. And
Yes.
once again, I explained to the patient that I will be touching his ankle and foot, and if he's having pain at any time of the examination, please let me know. Then I systematically then I look for any local rise of temperature with the dorsum of my hand. Then I palpate for any tenderness along the bony prominences, which include the medial malleolus, the lateral malleolus, then the calcaneum, then the midfoot, including the tarsal bones, then the
Patient
metatarsals
is
and the
tender
phalanx.
on the lateral aspect of the ankle. Okay.
Then I also look for the pulses, including the dorsalis pedis pulse and the posterior tibial artery pulse. Then I move on to check the movements of the patient, which includes both passive and active movements. I initially ask the patient to actively dorsiflex and plantar flex, as
This
well as
patient is
do
in
eversion
pain,
and
so
inversion of the
patient
knee.
has limited movement.
Okay, ma'am. Next, I would like to check the passive movements, and if he is having, and I try to do the above mentioned movements, including dorsiflexion, plantar flexion, eversion, and eversion, without in whatever range of movement the patient is able to bear the pain. Then I would like to do the special tests like the talar tilt test. I will stabilize the leg with one of my hand, left hand, and then cup the heel with the other hand, and then do.
What does this test
And
confirms?
if the test, if I'm doing an inward rotation at neutral angle, and if there is an opening up of pain on the lateral side of the ankle, the patient is having a calcaneofibular ligament injury. And if
Yes.
it is similarly the pain is appearing in plantar flexion, then he is having an anterior talofibular ligament injury.
So tilt
And if it is
test
in
is positive
dorsiflexion,
in this patient, in your patient. Yes.
okay, then I would like to do the anterior drawer test.
Yes.
Uh, in
How would you do that?
Here also with the patient sitting, I will stabilize the tibia with one of my hand and cup the heel with the other hand. Then I will give a anterior directed force on the foot while stabilizing the leg with the other hand. And if there is undue movement compared to the opposite side, then it suggests an ATFL injury, anterior talofibular ligament injury.
Okay.
And moving forward, I would like to do the Simmons test.
Yes.
That is by asking the patient to kneel on a chair with his feet hanging off the edge, and I explained to him that I will be squeezing his calf, and I will check for the movement, plantar flexion of the ankle. And if it's happening, or if there is plantar flexion, that means his Achilles tendon is intact.
Patient has
And
intact Achilles
that
tendon. Yes.
that completes my ankle examination, I will thank the patient and ask him whether he needed any help to get dressed up and wash my hands.
Okay, you still have 1 minute left. Okay, present your case. Kindly present your case.
Today,
Yes.
I examined a 19-year-old gentleman who presented with a sports injury to his right foot and ankle. And on examination, the patient is having antalgic gait, and there is swelling of his ankle, mainly on the lateral aspect. And there is no local rise of temperature. And on examining the movements, the patient is having painful movements, both active and passive movements are painfully limited. And on doing the special test, it was found that the Gala tilt test was positive and the anterior drawer test was negative, and the patient is having
So what is your differential diagnosis?
my primary differential will be a sprain of the ankle, ligament injury, and my
Which
other
ligament
different
injury? Calcaneofibular.
calcaneofibular ligament injury.
Yes.
And my other differentials include any fractures of the bones of the ankle or the foot, including the both malleoli or the metatarsals or the
Yes.
tarsal bones.
How would you investigate your patient? How would you confirm your diagnosis?
I would like to take an X-ray of the X-ray of his ankle, including AP, lateral, and mortise view,
Yes.
and look for
And
any bony injuries.
yes. What management would you offer your patient?
And since the patient is having a ligament injury, I would like to manage the patient conservatively. I would like to give a ice pack, compression bandage,
So you'll offer
and
conservative
elevation of the limb.
management first.
And
Yes.
yes, yes. And if
Yes.
there is severe swelling or severe pain, then I can manage him with a posterior slab or immobilization with plaster slab,
Non-weight bearing back slab. Okay.
non-weight bearing slab.
If X-ray shows undisplaced fracture of fibula with swelling of the ankle, how would you manage your patient?
If it's an undisplaced fracture, then I will discuss with the patient and about the options, and I will suggest him about the conservative management, including non-weight bearing plaster cast immobilization, rest, ice, and anti-edema measures, including NSAIDs.
Good. Energy, yes. Good. Within time. Excellent. This was his first time. That's why he was little reluctant. You could tell. Otherwise, he knew everything.
I
Thank
have
you.
to say one thing, that in fractured fibula, if you are applying the slab, then you cannot say use ice. Once you applied the slab, then there is no use of ice.
Okay.
Okay. And maybe at the end, when you say you'll discuss with the patient, you basically in UK discuss with MDT, and then you inform the patient. You don't
Okay.
discuss with the patients or relatives. You discuss with the MDT, your own doctor's circle, and then you just inform them. Otherwise, it was good within given time, without. Was your first time, so
And
anyone
one
else
more
want to
thing,
give?
ma'am.
Yes, please.
He has to say that I'll examine the opposite leg also to compare.
Yes.
That you have to
Contralateral.
mention whether you do or not.
Yeah, you have to say it to complete. Yeah. So contralateral. This one very good. Okay, it never came in my mind as well while giving feedback. So this you have to mention. Good. Yes, Dr. Abhishek. Anything else?
No, it was really a good one, Dr. Bharti. And I'd like to say, like about the challenge test, you can mention the three positions, like it will help you to discriminate between it is anterior talofibular, posterior talofibular, or calcaneofibular. So you can give a brief discussion, like in 10-degree plantar flexion. I'll do that just in 10-degree plantar flexion, 10-degree dorsiflexion, and neutral position. That's it. We can just add up.
Yeah. Good. Excellent.
Okay.
Yeah.
Thank you.
That's every point.
Thank you.
Yeah.
Yeah.